So we're going to have a little bit of time to take questions. It is 10:19, so we're going to go till about 10:30. And so if you have a question, please raise a hand, and we'll get a microphone to you as quickly as possible. If we have questions coming in from folks that are streaming the event online, please let me know. I do need a microphone right over here towards the front on the right side, and then we've got another question in the back row after that. Neil, thank you so much for your presentation today.
You're welcome.
I felt like I just relived your 2-day seminar in about 45 minutes, and oddly, I think more of this will stick for me.
That's great.
So let's take a look and see what our question is here.
Hi, thank you so much
Madison.
for that fantastic talk. I have a question in terms of supplementary material, in that it's something that I often ignore, and I've been delving into it more recently, and they often hide a lot of interesting data in there that they never mention in the paper. So what is your attitude about trying to take advantage of supplementary material whenever you're reading a paper?
I think that's a really great question. I think supplementary material is a fantastic thing because now most things are published online. There's not the issue of word count so much. So people can put all the available information, but people cheat and they abuse it and they hide stuff that should be in the paper, headline stuff, in the supplementary information. The solution for you guys or everyone else is read the supplementary information. We were critiquing a systematic review in our workshop, and it was a systematic review of treatments for tennis elbow. And the main meta-analysis, rather than being a meta-analysis of treatment effect, was a meta-analysis of how much people change from baseline, which is completely not the right analysis. And that was the only analysis presented in the paper. And they presented the actual analysis that could tell us whether the treatment worked or not in the supplementary information, which interestingly no one in the workshop had checked. So they do absolutely squirrel it away. I think, without being a nihilist, I don't think you should ever assume good practice. My view on papers is it's actually quite fun to be a detective, right? To assume that something might be hiding and go looking for it. And if you can't find it, then you give the benefit of the doubt. That would be my view.
Great, thank you. The next question is in the very back of the room. Again, anybody that has questions, please let me know by raising your hand.
I just wanted to know your thoughts on pre-registered, I'm back here, sorry, on pre-registered trials and just your thoughts on it and why we don't use them more, or maybe we shouldn't be using them.
Well, as in registering the trial protocol beforehand? Well, I would say that the vast majority of trials would now make it to a register, but they wouldn't necessarily publish a detailed protocol, and registers are quite inconsistent in what they report, and they're often not updated, and a bit like ethics committees, there's never really a system of audit to make sure people are actually keeping honest. So often I think researchers fall into the trap of registering their trial, but they never go back and tell us what they did. So it would be quite rare for me to find a trial now that isn't registered, but the register document doesn't often tell me everything I need to know. So we're moving to a position where the good trial groups will publish a full detailed protocol in a journal like BMJ Open or BMC Musculoskeletal Disorders. If you're reading a trial as a user, I think it's really useful to try and source the protocol and have it next to you. And it might be you don't look at it, but if you think something doesn't seem right, it's very quick just to go back and make sure that the plan is the same as the outcome. And I think what we've seen in the slides is the plan often changes, and that isn't always transparent. It's actually okay to deviate from protocol if you report it and explain why, and it's all very transparent, and we as users can interpret what impact that might have had. The cardinal sin is to change from protocol and tell no one about it. Does that answer the question?
Yeah, I guess I was thinking in terms of pre-registering a trial so that it gets published regardless of what the results are.
Right, yeah.
And you might see that more in the UK but I feel like I don't see it a whole lot here in the US as far as registering a trial and then having the confirmation that it will get published as long as you adhere to the methodology, but that regardless of the results, the study gets published.
Sure. I mean, I think probably even here, trials get registered, but where the big problem is they don't get published afterwards, right?
Exactly.
And you know, that's trial registry was a great idea, but the follow through on it hasn't been fantastic. I don't know if you're aware of the All Trials campaign that's been spearheaded by Ben Goldacre, but that's a campaign to try and make sure that everything gets published. It's an ongoing tension. It's a big problem, absolutely.
Do you see it in academia? I'm in academia as well, and the need for folks in academia to publish and the pressure to publish poor trial, you know, just to get something out there because you have to produce scholarship.
Well, I'm subject to it, yeah. I mean, I think there are all sorts of perverse incentives in academia that encourage bad practice, and publish or perish is one of them, you know. But as researchers, we've got to try and resist that, and that's hard if you want a promotion sometimes.
We had another question, not the second row, though I know you're next.
Thanks. I had a bit of a question. Effect size eludes me all the time in terms of when I'm reading the research. So I'm hoping that you might be able to take a moment and just kind of boil it down to brass tacks in terms of how you can interpret effect size.
Yeah, that's kind of hard. I mean, it depends on the outcome. So I've got a 1 hour lecture on it. But I think it depends. If it's a pain score in a single trial, then it should be the between group difference on that pain score. So if it was 2, then it would mean that on average, pain scores after treatment were 2 points better in one group than the other. And you need the 95% confidence intervals around that to get an idea of the precision. But if it's a dichotomous outcome, like did they respond to treatment or not, then you would use the risk ratio or the risk difference, and from that you can get the number needed to treat. My view is that the number needed to treat is quite intuitive. I would need to treat this many more people than the comparison treatment, with this treatment compared to the comparison for one more person to experience a treatment response. So if you have a trial that uses a responder analysis, they should be presenting that data with the confidence intervals. It gets harder with systematic reviews where they pool a number of studies together that measured the same construct like pain or depression, but they all use different scales with different scoring properties. And what they do then is they use the standardized mean difference. And that's not the same thing as the mean difference on a pain scale. The standardized mean difference normalizes each study in units of standard deviation. So if you see a standardized mean difference of 1, that means on average, the treatment group were 1 standard deviation better than the control group. But that's kind of meaningless, unless you go back to the data and say, well, how big was the standard deviation on the original scale? So SMD is a useful tool, but it's very hard to interpret. I mean, but I'd be more than happy to chat with you about it afterwards, but it's a long conversation.
We have a gentleman near the front here.
Hi, I really enjoyed that, thank you very much. And I'm looking forward to reading your paper on bimodal distributions, because that's something that I've been thinking about a lot with people, outlier kind of high responders, low responders.
Sure.
My question is around study design, and we're inherently dealing with, like you say, complexity in biology, and so we have some problems with comparing A with A plus B. Yep. Design, so general exercise versus general exercise plus dry needling, say, because the people in the A plus B design get more intervention. Yeah. And so I just wonder, like, and we don't even really have anything that is best practice currently, because everything works about the same as everything else. So,
or not. Yeah.
So what are your thoughts on the optimal kind of study design, and how to evaluate study design when we're reading something?
It's very dependent on the question. I mean, I don't think there's no value in an A versus A plus B design, but as you say, the problem is the imbalance of attention. But if you just want to pragmatically ask the question, does delivering these 2 treatments deliver more benefit than just the one, and you're not worried about how that happens, then there's no problem with that. If you're wanting to control for that imbalance of attention, then you've really got to throw in some kind of inert balance for that attention. And that can be hard to do. With needling, it's not so hard because there are ways of sham controlling for that. But you know, if it's CBT, I mean, some studies have tried to do placebo CBT, and it basically consists of a chat and a cup of tea. And you think, well, how credible is that? Another study, sham manual therapy is just getting someone who looks authoritative just to put a hand on the back. And for me, that wouldn't be as credible as someone, twisting and clicking and crunching me. So it's hard, and there are limitations to what you can get. If you're interested in pragmatic questions, it doesn't matter so much. But if you want to get to the why, it absolutely does. I don't think there is an optimal design. I think it just depends on, you choose a design that fits the question. In the same sense that I've talked about RCTs today, but I really want to make the point that they're not the only useful source of evidence. They're by far the best source of evidence to get on average is our treatment delivering benefit. But they're not the be-all and end-all of evidence-based practice. So I guess in answer to your question, it is tricky. You should pick the best design that gets you closest to interrogating the answer you want. As a user of evidence, you should be aware that they might have used a design that isn't ideal, and they might have done that with an agenda. I don't know if that answers it or not. But.
We're coming right up on our time, but we've got one last question from Mike Stewart, and then we will take a break.
Hi, Neil. Great
Hi,
talk.
Mike. Thanks.
Hiya. That was really good. What I loved was the fact that you've just highlighted beautifully the complexity of this. It's so complex, isn't it? I was wondering about your thoughts on equipping patients with critical appraisal skills. I mean, because what I often see in practice is people who, they maybe feel empowered to go it alone and they feel liberated from some of this stuff, and then we see them again 3 years later because they've read something in the Daily Mail or they've seen something online. So maybe providing people in pain with some basic appraisal skills to assess how valid or reliable this information is.
I think it's a fabulous idea. I won't hear you attack the Daily Mail, though. It's a fantastic newspaper.
Of course.
I didn't say that. That's sarcasm right
It's
there.
on record.
So my view is, we're so busy talking to clinicians, but absolutely, we should be talking more to patients. But it can get tricky to do that. I think we need to develop very specific resources. Actually, that paper from Chalmers, that's specifically for a lay audience about trying to help people to make informed health choices and how to spot bullshit, essentially, and spin and all those other things. But, you're basically spitting into a very strong wind, aren't you? Because you've got this much voice and not the power of the mass media and the newspaper and the mainstream media have their voice. And it's very hard to not be drowned out by that. But my view on that is you just keep plugging away at it. I'd love the idea of trying to organise critical appraisal workshops for patient groups, though. I think it would be a fabulous thing to do. I think the hard part, though, again, would be convincing people that it was something that they needed. And that's hard to convince clinicians, too, of.
I agree. Thanks very much.
Thank you.
So I was informed that we do have just a few minutes delay if somebody wants